learn your faces because I usually find one or two people that if you have been trained and at the like 45-minute mark of somebody droning on up here, you look like you want to die a little inside. And so that becomes my cue to be like, wrap it up, we need break time. But right now, you all have that look. So we'll be having to pick that out a little bit. But please, somebody, if I start getting really excited, because I get really excited about this stuff, stop me. Just make sure you get your break time. I will not be offended. I will just pick it back up in 10 more minutes. Okay, so this officially then starts testable material of what you are going to need for pediatrics. So welcome. So the neonatal period. We just talked about the neonatal period. What does that even mean? Yeah, so that's where we're going to start. At the beginning, I put all of your different learning objectives. The reason, I don't expect you to read them. If you're reviewing slides and you want to get rid of them, that's fine. But I test based on your learning objectives. So if there's a topic that I just really love, and there's like one learning objective on it, there may or may not be a question. There's a topic that has 17 learning objectives. There's going to be a couple of questions about that. So we'll put your learning objectives there so you can gauge of how important some of these things are. So again, we talked about that age. We're going to talk about that. So we're the newborn, how do you resuscitate them? What do you need to do immediately? What do you need to do when they're in your nursery? What does a physical exam specifically for this look like? Because this is going to look vastly different than anything that you've done in a clinical skills lab up to this point. And then what happens when some of that goes wrong? So that's where we're going with this lecture. I always will put your PANTS blueprint. So this is about 4% of any given PANTS exam has some sort of neonatal care involved in that. So that's just a reference. I will speed through those every day, but just so you understand why I put those things in there. So the prenatal. So now we're not even at the neonatal, we're at the prenatal period. So we are looking at that. So definitionally wise, there's different developmental stages even before a baby is born. Right? So anything in that prenatal period is before birth. So up and through that first 8 weeks, we have the embryonic phase. And that's why I bring in a lot of those things from embryology, because that is the formation of all of those parts and pieces. And then the fetal period, so 9 weeks on, where all of those pieces then grow and continue to develop. So if you're looking and thinking, what's the most important and critical stages for an infant's development, is it likely the embryonic or the fetal period? Embryonic period, correct. When would you need to make interventions then for things to prevent things like spina bifida, where you don't have enough folate in those first few weeks? The embryonic period. How many people do not even realize that they are pregnant throughout the whole embryonic period? A lot, right? So that is what some of the things are. So that is why some of the time you are thinking, I have 2 patients here, because my patient is growing and developing in mom, but mom's got to do this thing to prevent that thing. That makes sense, right? So that's why we care so much about the embryonic period and so much about prenatal care, and that you have a whole OB-GYN and women's health course, is because that's when things can go awry, right? So again, we're trying to prevent some of this stuff. 3 trimesters, then you're also split up into, it's another way to think about it. So first, second, and third trimester, as most people are familiar with. Again, the first trimester is going to have that embryonic period, so just going to be the most important. And this is again why we get the HCG on every female of childbearing age. So different ERs, different clinics will have different protocols on that. I believe CMC's protocol right now is anyone over the age of 10 gets an HCG. There are 10-year-olds that could be of childbearing age, so 10 and up get an HCG for that very reason. We have to know if we have 1 patient or 2 patients on our hands. So because we have that second patient and what we are looking at here, we need to know things about our, kind of think about it as our second patient. So we need to know a lot about mom's status here. So mom's status is going to be a big history. Has mom ever been pregnant before? If so, was it a high-risk pregnancy? Meaning, how's that placenta? Was there a giant line and scar in it because she had a C-section last time? Did she try to bleed out last time and have an intrapartum hemorrhage? What was going on there? What were those complications? Does every baby she have jaundice issues? Did she have multiple babies that had sepsis? Right? So those are going to be important for our patient that is at hand. Same thing with OB. Did mom have prenatal care? So we take for granted in the military, everyone has prenatal care. Absolutely not. You're going to get on the outside. How many are reserve and guard in here? Yeah, so you guys are going to get out and be like, wait, you didn't know you were pregnant? What's going on? How did this happen? Right? And you have none of this prenatal care. Are they infected? What are they infected with? You oftentimes will have no idea. Then you have your fetal history. Did we have any kind of abnormal ultrasound? Did we have any ultrasounds along the way? Right? So all of this is going to be history to stratify how much risk you have at any given point. So one of the first things that we're always going to do is NIPT testing. So NIPT means non-invasive pregnancy testing, or prenatal testing. So we do either non-invasive prenatal testing. So what they do in NIPTs is they take some of mom's blood and give it or take 6%-ish. You spin it down, you will have 6% that are fetal cells, and you can test those fetal cells without having to go through the placenta or do any kind of chorionic villus sampling or any kind of amniocentesis. So that is what a NIPT is. So the most common NIPT screening, non-invasive prenatal testing, is going to be the quad screen. You guys are all very bright in here. How many things do you think the quad screen tests for? 4. Yes. Anybody have any idea what those 4 things are? Not CF. We'll talk about where that's tested. Down syndrome. What's the other name? What's the provider term for that? Trisomy 21. So what other trisomies do we test for? Trisomy 13, I heard that. And then trisomy 18. Correct. Why do we test for trisomy 21, 13, and 18? They're the most common. Why are they the most common?
Because babies can be born with them.
Correct, because they are compatible with life. Right? So all the other trisomies, you could have trisomy 2, you could have trisomy 12, you could have trisomy, pick any of your chromosomes. They are not compatible with life. But the ones that are compatible with life are 13, 18, and 21. So those are the 3 we check for. The other thing that is on the quad screen is an AFP, an alpha fetal protein, and that looks for spina bifida. We'll talk a whole thing about spina bifida. So the quad screen, the NIPT, has those 3 trisomies that are compatible with life and your alpha fetal protein. The harmony screen is very similar to the quad screen. It's the quad screen plus. So the quad screen has all those same things, and then it looks at the baby's sex chromosome. So do we have an XX, female, or an XY, male? Or do we have an XXY, or an XXXXXYYY, or an XYY? We have all kinds of variations that we have. We'll talk about that in a different lecture, but you look at the baby's sex chromosomes. So quad screen plus that is what your harmony screen is. And then there's all kinds of different ones. These are just the most common ones that I want you to be aware of. But in general, when someone says NIPT, it means they took mom's blood, not baby's. Things that we want to know then about mom that are going to specifically affect baby. Okay, so mom's hypertension. What you need to know about babies as they develop, and this is going to overlap when you start in obstetrics, is for a baby, if you have no flow, you have no growth. No flow, no growth. So those things were going to go together. So if mom has hypertension and the placenta is not getting a whole lot of blood flow, not as much blood flow, that baby is not going to grow. So a mom with hypertension is going to result in a very small baby. Okay, no flow, no growth. Diabetes, kind of the exact opposite. If mom has high levels of glucose that are circulating, that are going to preferentially shunt to the baby is going to get all this glucose going straight to the baby. And what do you think that that does to the baby's pancreatic cells that are learning to make insulin? It's going to say, yeah, we need to make all this insulin going. Make the insulin, make the insulin. What happens when they come out and they're not getting glucose from mom then? Oh no. And they drop really fast. And now you have a baby seizing because mom had diabetes and there's so much insulin in the baby, you have a bad situation. Hypo or hypothyroidism. You will learn in pediatrics, there's a couple of things that you can say. So maybe maybe I shouldn't say this, but if any of you grew up in church and you could like say the answer is Jesus to everything, very similar to saying thyroid issues or sepsis. It gets the right answer all the time. So if you really have to guess something in pediatrics, guess thyroid or sepsis, right? If you like know nothing else on rounds and you're like, sepsis, you're probably right. Or like hyperthyroidism. So the reason that is because you have a little miniature human who is not done differentiating. They haven't proven they can successfully make it to adulthood. And that is done by a thyroid. That's for organ differentiation, right? So if mom has low thyroid or high thyroid, and the baby's organs are trying to differentiate, we have a big problem on our hands. So mom's hypo or hyperthyroidism can make a big deal. How about anxiety and depression, right? So you're like thinking, mom's anxiety, mom's depressed, how does that have anything to do with it? Well, for those of you who have ever been around a child, how do they communicate? They cry. Do they scream? Yeah. Do they sleep super well? No. Well, yeah, in fits. But we'll talk about infants later. So you've taken somebody who is already potentially anxious and or depressed. Now you've handed them the screaming infant who doesn't sleep very well and say, good luck, right? So that's what we've done. So knowing that up front can help you risk stratify and get those resources to those families on the back end. Not severe anemia. If mom is low, how well is she going to transport oxygen to the baby then? Not great, right? So mom's anemia can severely affect the baby. Very similar situation to that no flow, no grow. And then if mom has malignancies, might not directly affect the baby, but it could. And it could affect if mom is choosing to do some treatments during the course of a pregnancy, because you can have side effects from the medication that are directly going to affect the baby. Things that we're also going to look at, so that was mom's stuff. So we're looking at the history of mom and their dyad together. Then we looked at mom's medical history. What about the babies and this particular pregnancy's medical history? So one of the things, and again I said sepsis is always a correct answer because the highest and the most common thing that goes wrong is going to be some sort of infectious etiology. So something is going on, and that puts infants at risk for growth issues, for deformities, for fetal demise, for early preterm deliveries, all kinds of things going on with those. And we will talk about specific ones that are trimester dependent. So it might not be a big deal at all if at 37 weeks you get rubella, but it's a really big deal at 16 weeks if you do. So time dependent things are going to matter. And I'll give you specifics on that one as we get there. So trimester dependent. These storage infections are the ones that are the most common, or the ones that are the most predictable, and I'll tell you what I mean by that. I always say that I learned these as the torches infections, and the S was at the back end. Well, S stands for syphilis, and the syphilis has made such a large re-emergence, that we have moved it back to the beginning, and it is now these storch infections, not torches. I want to highlight that syphilis is on the rise. So that's just the only place in the military, a fun fact from residency, that I have seen congenital syphilis was at Fort Hood. A lot of syphilis at Fort Hood. Yes, ma'am.
Are these listed in order of like most offensive photographs?
No, that's a good question. Are they most offensive and not? No, the reason that these particular ones, because the O is other, which is mean, right? So you have syphilis, toxoplasmosis, other, talk about, rubella, CMV, and HSV. The reason that you have those specific ones that are listed with those is they have a very predictable pattern. If I have congenital syphilis, I pretty much know how that's going to go. If I have toxo, I pretty much know how that's going to go. The other ones, varicella, well, I might know they have varicella, but the phenotype of that can look very, very different. How it's expressed, the severity of it can look very, very different. So anything that is in that other category, HIV, hepatitis, varicella, parvo, gonorrhea, chlamydia, all of the other ones are still things that we worry about, screen for, put on our differential treat, but they are not as predictable in the way they are expressed. Okay? The STRCH, they are, and they're Not necessarily one's worse or not, but the prevalence that we see a lot of the times, and perhaps probably just in my own experience, HSV is the one that we see the most often and is the worst. The other thing to think about is what is the vehicle that we are dealing with. So obstetric complications. Has mom been bleeding throughout this whole pregnancy? Placental previa, and some of these, have you guys started women's health yet? I don't think you have. Okay, so placenta previa basically means the placenta is on top of the cervix. So how would you deliver when something is in the way? Right? So do we have previa going on when you have to do a C-section? Do we have placental abruption, where the placenta is trying to detach part of the uterine wall as well? It's not just coming apart nicely, it's pulling the wall with it. Right? That's going to make somebody potentially bleed out. It'll be a really big deal. Oligo and polyhydramnios. So which one of those, just based on the terminology, do you think is too much fluid and not enough fluid? Which one is too much fluid here? Polyhydramnios, correct. So do we have not enough fluid? Oligohydramnios. Right? Are we leaking fluid? Are we not making fluid? What's happening? Or do we have way too much fluid? We'll talk about when there's a baby with polio, something is not going right here. Is there an infection from the cervix? Is it an ascending infection, a vaginosis? And then a couple of things that we want to do is to be able to speak provider to provider is one of the terms when people say rupture of membranes, that is now the provider speak that you will use from here on out for when someone says, my water broke. Okay? So someone says, what time did their water break? You're like, what? That's layman speak. You're going to say, rupture of membranes was at X time. Okay? So, when you say premature rupture of membranes, you are saying that the water broke, or the amniotic sac broke, before labor was initiated. Right? So the body is not getting those signals right. So the uterus is just still sitting there hanging out, not contracting, but the amniotic sac ruptured. So now you're like, wait, so now I just have this child who has a pathway to the world, and the uterus is just like, yeah, we're not ready yet. Okay, so now you started the clock. So as soon as you have ruptured membranes, the clock starts, like down to the minute. If you're like, what time is that? 12:13? Okay, 12:13 is the time of rupture of membranes. So to the minute, you care about that rupture of membranes. So if the uterus is not contracted yet, but you have that is premature rupture of membranes. Jump to the bottom one. Now you have prolonged rupture of membranes. So if it was 12:13 when you had a rupture of membranes, and it's been 24 hours, and now it's 12:14 the next day, now you have prolonged rupture of membranes. And then if you have a preterm infant, we'll go over that definition in a minute, a preterm infant, and you have that premature rupture of membranes, and it's prolonged, you can have all of that. So you can have PROM, so that would be the first one, premature rupture of membranes is PROM. You can have PPROM, so you can have prolonged preterm rupture of membranes, and then you can have PPPROM, premature, preterm, prolonged rupture of membranes, and any combination thereof. Okay, so those are what the number of P's stand for in accordance with rupture of membranes. So you need to know those things as well. Something to know, if a child dies in utero between 20 weeks and any time after, so EGD means estimated gestational age. So anytime a child dies from the 20th week of gestation up until they are no longer a neonate anymore, that is considered a perinatal mortality. So anyone in that, so just to get us on the same page. Most common reason that's going to happen, so some congenital anomaly, something genetic, something is going on there. Infection can be another one of those common ones. And then prematurity. So I have beef with this, and your textbook. So in a pediatrician's world, true prematurity is anything below 38 weeks, but for gestational purposes, for everything else, for the way that OB-GYN measures up, we're going to use 37 weeks as our definition. So in my world, that is considered early term, up to 38, but we're gonna call 37, so that's our cutoff, 37 for all of us here. Anything below that is considered prematurity. Okay? So if you're thinking on a test, I'm not gonna try to trick you with like, it's midnight at 36 and 6, it's midnight, it's 37 to the, like if it's preterm, I'll give you preterm. This is a 34 weeker, this is a 32 weeker, this is a 35. I'll give you something that is very clearly less than 37. Other things that could go wrong, so intrauterine asphyxia. Is there a knot in the cord? Is the cord prolapsed and literally kinked off? Is there multiple gestation and all of the nutrients and all of the blood flow is shunting to one baby versus another? Is there some sort of infection? And then is the placenta unable to nourish? Is there a bleed in between? Is the cord? There's a million reasons that something could be wrong. You can have placental insufficiency. So this is what happens when all of those things do not go correct according to plan. So when you get to OB and you start thinking about this, these are some of that kind of background information that you will need. Again, we're going to call less than 37 weeks premature. And the reason that we're saying that is because that is where the physiology particularly matters. Because when you are preterm, you are predisposed to some of these things that once you are older, you're really not as much at an issue anymore. So, for example, we will talk about all of these specifically, but we're going to preview them now. So, respiratory distress syndrome. That, in a premature child, means that their lungs have not created enough surfactant yet from the type 2 pneumocytes of the alveoli. Okay, so they have no surfactant. What does surfactant do? Go way back to pulmonology. It keeps the surface tension, so it keeps them from collapsing. So if you have a premature infant who may or may not have the neurological ability to even remember to breathe, and now every single breath they have no prevention of surface tissue, and it's barotrauma every time, eventually that child is not going to do well. So that is what JFK's third child who died from, respiratory distress syndrome. So we'll talk specifically about that when we get there. Immaturity. You literally, like I just mentioned, you don't even have the drive to breathe until a certain age. Their little bodies have not made surfactant. Their gut is not able to handle breast milk. There's a lot that goes on into those immaturity stages. Intraventricular hemorrhage. So the vessels are friable. There's kind of leaky vessels. So if all the vessels are supposed to be really tight together, all of this is going on and they have these leaky vessels. Super easy then, when we as providers get in there, we're like, I'm gonna bag this baby, I'm gonna do chest compressions, to all of a sudden accidentally end up with an intraventricular hemorrhage because these vessels are pretty friable. And then necrotizing enterocolitis. The gut itself is having gut ischemia and dying because it is unable to handle the nutrients because it was used to getting glucose from the placenta. And now all of a sudden we're saying you're premature, gut, work anyway. It just doesn't work like that. So they are predisposed to some of these things that we will talk about in detail. And that is going to be different than if you're a term infant. So if you're greater than 37 weeks, so 37 basically up to 42, well, you're at risk of asphyxia, right? The birth process can be pretty traumatic. And then any of those other congenital anomalies, genetic issues, chromosomal abnormalities, and then infection, again, it's like sepsis. Infection can always be an answer for something that has gone wrong. So now we are at newborn care. Okay, so that is all the background to make sure we are on the right same page as far as what we're doing here. So now we have mom in labor. Okay, we've gone through the chart and we've said, I know mom's history, I know this pregnancy's history, I know what we know about the baby, I am ready for what is going to happen. The baby is born, you are in the delivery room as the Peds team, the baby comes out, and the baby is handed to you. What do? Hand it back is not the right answer. You cannot say that, right? That's what we're going to talk about. So the first thing we are going to do, from the moment that baby comes out, somebody is going to call the timeout. So if the baby was born right now, they would literally say, time of birth, 3:42, or 15:42, right? And that was literally somebody's job on the warmer, it's called the warmer, is to sit there with their finger on there and push that button the moment they are born. Okay? That starts the clock. We need 1 minute on the clock. 1 minute. I wanna know what they're doing at 1 minute of life, and I wanna know what they're doing at 5 minutes of life, so we'll talk about that, right? If the baby is stable, we'll talk about what that means here in a minute. If the baby's stable, then all of the next assessments and all of the next thing you will do as a provider can happen while the baby is still attached to or on mom. The baby is unstable, the cord is clamped and cut, and the baby moves over to the warmer and to the care team. So your first thing is start the time. Is the baby unstable or stable? You determine that using your APGARs. You next will get a physical exam, and we'll talk in depth about that. Establish feeding, so I don't care how you feed. Specifically, people will say, well, is breast milk better or is formula better? Feed them. Fed is best. And then there's a whole thing that we do at the 24-hour mark. Most babies will get to go home between 24 and 72 hours, depending on how the delivery went, what's going on in the background. If mom had a C-section and mom's not ready to go, or the baby there's concern for sepsis, certainly they're gonna stay longer. And then if they're ever considered unstable, they go to the NICU. A little bit of a thing to think about with medicine. There's a lot of, so what does ICU stand for?
Intensive care unit.
Correct, intensive care unit. So whenever you put a letter in front of that, the MICU, the SICU, the TICU, the CV, ICU, the NICU, the PICU, any of those, any letter in front of that tells you that there's a different physiology. Okay, so now that we have a NICU, it tells you that that's a different type, that neonates have a different physiology than the pediatric ICU, the PICU. Okay, so any ICU that you go to, the SICU, the surgical ICU is going to have a different physiology than the MICU, the medical ICU. Right? So that letter in front of it is going to be very important to know where you are, just care-wise and physiology-wise, as you go forward as a provider. Thing to know, first little pearl here, if you go out to a small base, small post, small boat, know where your nearest ICU, your nearest NICU is, right? Because if you have any kind of ER urgent care, people are going to see that sign and come in off the street, try to deliver, and you got to know where that is. Or if there's somebody living on post that was like, I didn't know I was pregnant, or there's a million scenarios. One thing you need to know, where is my nearest NICU? So things for APGAR. Does anyone know who that lovely lady is in the corner?
Who created that?
Close, close. So this is Dr. Virginia APGAR. I think she's amazing. She turned her last name into what we still use. So basically what was happening, she was an OB-GYN and an anesthesiologist. Like, that's cool. But what she was seeing and she was looking at is that with antibiotics, and after World War II, in the 30s, 40s, and 50s, you were seeing infant and maternal mortality, but for our cases, infant mortality dropping, right? Like these babies that were dying, they were suddenly living, except in that first 24 hours. So the 24-hour mortality rate was still not great, not at all. And so what she was starting to look at was why? How do we predict that short-term outcome? We figured out some of these longer-term outcomes, but how do we fix this 24-hour window of mortality? And so she came up with the APGAR that, again, pretty cool, it's her last name. So appearance, pulse, grimace, activity, and respiration. We'll look at those in detail. You can either get a 0 if it's real bad. You can get a 1 if it's okay. And you can get 2 for full credit. And that is going to predict what needs to happen. So we'll specifically look at that. So on those 5 categories, if you add those points up for all 5, and they are an 8, 9, or a 10, you are good to go. Your risk of infant mortality at that rate is little to none. Continue to fly on. If you add those up and you have a 4, 5, 6, or 7, it's telling you that some intervention needs to happen in that very short window. And if you are a 0, 1, 2, or 3, there are serious complications and this infant will likely die without intervention. Okay? In that short term, right? So if I ask you, I don't know if anyone in this room knows their APGAR scores, right? Does anyone know what their APGAR scores were? Right, perfect, right? That should show you there's no long-term outcome whatsoever to do with this. This is short-term, 24-hour mortality stuff. That first minute, the reason I cared, start the timer, 60 seconds on the clock, is at the 1 minute mark, You are scoring these, and this is a reflection of how did birth go? How did that baby tolerate birth? Right? So that is what your 1 minute APGAR is looking at. How did birth go? Keep going, that timer's going. At the 5 minute mark, now you're looking at how is that infant transitioning to life, right? So if you're in that 7 or below, something's not going well, and that's telling you that you need to continue. So if you ever are getting a 7 or below, that is going to tell you you need to continue. I need a 10-minute APGAR every 5 minutes until you get an 8 or above. Right? So if I get a 6 at minute 1, ooh, birth didn't go so well, let's do some intervention. At 5 minutes, I get a 7. Yikes, we're still below that 8. I need a 10-minute APGAR. If we're still at 7, I need a 15-minute APGAR. Still at 7, I need a 20-minute APGAR. Oh, now we're at 9. We're doing pretty well. Right? So it's giving you that short-term intervention. It's not a long-term predictor of intelligence or anything else. Again, nobody in this room knows their APGAR. So we could have had, and probably do have people in here who had a 2 or a 3. Right? And then some of us who had 8s and 9s. I have no idea what mine was. And this is super cool because this really hasn't changed from when she introduced these in the late 60s, right? So that's pretty impressive to have something and some assessment tool that really hasn't changed in, 60 years, public math, right? Pretty impressive from that standpoint. So how do we calculate this then? 49. Before we do that, let's take our 10-minute break, come back on the hour, and we will talk then about another Monday. Woo! I did forget to tell you one thing. Number 1, can you guys hear me okay in the back? Just to make sure. Back down. Sweet. One thing I forgot that I'm going to try to help teach in this class as well is there's a whole subculture of pediatrics that you need to be aware of, you need to know is very fundamental. I cannot believe I forgot to show this in the first hour. So, 2 things that I will always have with me at every lecture. If I don't, then you can come kick me in the knees. Suckers and stickers. Okay? These are the 2 things that every pediatric trained provider is going to need. Suckers and stickers. Okay? So if you're having a bad day, you just need to wear a little heart sticker, have a sucker. I will always have suckers and stickers. Okay? Suckers and stickers. So back to the APGAR. Is the APGAR for short-term or long-term prognostic indication?
Short-term.
What minutes does every child get an APGAR score at?
1.
What does the 1 minute tell you? How did it in birth? What does the 5 minute tell you? How are you adapting to life? Okay, so that's what it is. But let's see what we're going to do. So this is what we're going to do for a lot of pediatrics. We learn what's the bad, we learn what's the good, and then somewhere in between is what the middle score is, okay? So if we're looking at APGAR, appearance, pulse, grimace, activity, and respiration, we are looking at appearance. We are looking at what color is this child? Are they completely cyanotic, blue, gray, ashen, head to toe? That's 0, right? Are they completely pink? Not an ounce of blue, gray, or ashen amongst them. That's a 2, right? If there's some blue, some gray, some pink, that's a 1. Okay, so you learn the 0, you learn the 2, and then what's in the middle is the 1. Okay? Something to know specifically with that one is that acrocyanosis is what almost every single baby will have, meaning their trunk and their head and some of their kind of proximal extremities are pink, but the hands and the feet are still blue. Because that takes a little while to get fully oxygenated. And so if somebody ever said they have an APGAR of 10, you're like, that baby is totally pink in 5 minutes? Like, okay, so I'm so sorry if your mom ever told you you were a perfect 10. Most babies are not perfect 10s for that reason. Most of them are acrocyanotic. Okay? So all blue, 0, all pink, a 2. Acrocyanosis is a 1. Your pulse. If you got no pulse, you got no heart rate, that's a 0. If you are over 100, that's a 2. Anything in between, that's a 1. Your grimace. So what do we say when we mean grimace? What we're really saying is what do they do in response to that bulb suction that we use? So we're trying to bulbs, we squeeze the bulb, put it in their nose, and then open it up so that the suction pulls all of the amniotic fluid out. And so if they let you do that and then they just don't care, that's a 0. If they are pissed off, they pull away, they sneeze, they kind of gag a little bit, that's a 2. And a somewhat in the middle is a 1. Activity, if you have a limp baby that just literally they look floppy, that's a 0. If you have a baby that has everything flexed, pissed, kicking, screaming like that, that's a 2. And then somewhere in between is a 1. Okay. And then finally, respiration, if they're not breathing at all, they're completely apneic, you have a 0. If you are breathing and you have a strong cry, so if you have a crying baby that is kicking and pulling away, that's what you want. Okay. So the strong cry is going to be 2. The weak cry, kind of anything in between, that's going to be a 1. So that's how you're scoring. So learn the 0s, learn the 2s, anything in between is going to be the 1 then. Okay. What I need you to not do is do not memorize this chart. I will give you every single pediatric vital sign that you will need in the top of every exam. Do not memorize Peds vitals. I don't have those memorized, right? What I need you to see from this is that we're really looking at, in general, the difference between the adult values and the pediatric values. So if you have a 0 to 3 month old baby who's at 150 beats per minute for a heart rate, you're thinking, that's pretty normal, we're doing great, right? If you have that in an adult, you're like, we should call the ambulance, you're in SVT, right? That's the difference. One's totally normal, one is like, you should go to the hospital, right? So what you're seeing is that in descending order, as the baby gets older, the rates of everything drop eventually to where they get to the adult numbers, okay? So I don't need you to memorize them, but have a little bit of an understanding that up till 3 months old, 100 is at the bottom of the normal heart rate. So if you don't have that upon coming out, that's a problem. Same for your respiratory rate. Your respiratory rate could be up into the 50s and 60s, right? If you saw an adult who was breathing 55 times a minute, you'd be like, dude, what's up? Are you okay? Right? You see a baby doing that? Totally fine. Totally fine. Something to note with that, usually you don't want a baby to breathe more than 60. So I know the premature ones say 70, and there's a reason behind that, but 60 is a good number because if you are breathing more than once a second, how efficient are you going to really be able to feed? Not well. Right? So 60 is about the cutoff. And then again, descending order. Your blood pressure. Let's talk about blood pressure for a second. What is the point of blood pressure? Where is it trying to get to? To your brain, right? So is blood pressure a function of weight or of height? Height, yes. So how far is it from a baby's heart to the brain? Not that far. So you don't need a whole lot of pressure. And then adult male, it's a lot higher, and gravity, right? So adult blood pressure should be higher than baby blood pressures where they're laying down and the space is like 3 inches. Function of height. So, a general overview of this. Yes, sir?
What's the 2 sides of the slide? Is that just like a high?
Diastolic, so 55 to 75 is diastolic, or systolic, and then 35 to 45 is diastolic. So you have all the systolic ranges and the diastolic. So again, please do not memorize this, but just be aware that you will always, even in the pediatric hospital, if you're going to work there, it will have charts and ranges for you. Again, we just talked about this. So respiratory rate typically is going to be every 1 to 2 seconds, so 30 to 60 a minute. The more premature you are, the faster you are going to breathe. It's just a function of being premature. The normal heart rate, again, 100 would be the bottom of the barrel there, but a normal rate is going to be anywhere from about 120 to 160. So again, what's your APGAR score if you have a heart rate of 80? 1, right? So great. So if it is that, so if you have a heart rate, most of the time, if you have a heart rate issue, if you have a cardiac complication with a child, most of the time it is from the respiratory system. Most of the time, their little hearts are just fine. And there's something with the airway or the respiratory system or oxygen exchange that is the problem. Okay? So if you have a heart rate that is above that 100, they got 2 APGAR points, they are good to go. You continue on with your routine care. If they are somewhere between 60 and 99, they got that 1 APGAR point, but it is still telling you they need some sort of respiratory support because likely respiratory is the issue, and that's what's going on. If you are below 60 then, now you're in a situation where it could be respiratory, it could be cardiac. You want to fix both. So 60 is your cutoff for that. So 100 for normal. That middle range, let's check ventilation and fix that first, is the 60 to 99. Less than 60 could be cardiac as well. Let's address cardiac and respiratory. Now we already talked about blood pressure. We're really not getting that because it is such a function of height. They're laying down and it is not much, only for the sickest of kiddos that go to the neonatal ICU. This is something else I do not want you to memorize, to be aware of it, right? You guys are going to learn BLS, basic life support. You guys are going to learn ACLS, cardiac stuff. In my world, I needed to know PALS, pediatric advanced life support. By the way, little plug for that, if you go to a phase 2 site and they're like, would you like to get PALS certified? Please do it. It just gives you a little bit more exposure to pediatrics. But you don't even do PALS in the setting of resuscitating a newborn. You do NRP, Neonatal Resuscitative Protocol, right? So it's its whole separate entity. The only reason I want you to show you that is this little box here on the side. And the reason that is important is because everyone thinks that when a baby is in utero, that their oxygen is at 100%, and that is not the case. The environment in the uterus, the oxygen is typically anywhere from 55 to 65, which is why they come out blue, because they're used to getting continuous oxygen exchange at that 55 to 65%. And over minute by minute, so this goes 1 minute, 2 minute, 3, 4, 5, 6, 7, 8, all the way to 10. That is when they go from that uterine environment where they were at that 55 to 65, and they come all the way up to 100. Okay? That's why they come out blue. It's why that we care and why we have a specific protocol for these infants. Right? So again, don't memorize the protocol. Know it exists and know why it exists. It's because that intrauterine environment has a much lower oxygen concentration because it's running continuous. Things that can lead to asphyxia then. So a couple of things we talked about. So number one, let's start at the bottom. Extreme prematurity, right? You're so young that you don't even have the neurologic maturity yet to know that you're supposed to breathe. So when you come out, you don't breathe. Right? So extreme prematurity could be one of those causes. You could have something in your upper or lower airway. So maybe you have a mucus plug. Maybe you have a blood clot. Maybe you have, any number of things that you have this obstruction. Maybe you literally have a mechanical obstruction because the head placement is not correct. So that could be another reason why you have asphyxia. Or you then have some sort of other disorder or something that is causing this hit to the respiratory or CNS drive. An infection could cause this. A prenatal stroke could cause this. Anything that's disrupting the placenta then could, in theory, cause that. And this is going to be my first stomping point that you will need to know to be able to think about this for block 2 and block 3. When you are hypoxic, let's say that just the oxygen started sucking out of the room right now, right? What is our physiologic response? Do we breathe faster or slower? We are going to breathe faster. A neonate's response to hypoxia is exactly the opposite. They respond with hypoxia with apnea, right? Oxygen sucked out of the room for these neonates, and they're like, oh, we don't have oxygen? Oh, I don't really know what else to do. And they just quit breathing, okay? So an infant's response to hypoxia is apnea, not tachypnea like ours, okay? So I will just hit that. You will be tired of me hitting that. So one of those things for the occlusion that you could see, that would be one of the reasons that they would go hypoxic, is because their heads are giant. If you looked at a child, you're like, your head, it's like having an egg on toothpicks. Like, what is going on here, right? Like, they're disproportionate little guys, right? So the head is so big that if the child is laying flat, the occiput comes forward, and you have a kinked airway, an occluded airway. That is why you put them in the sniffing position with something under their shoulders that lifts the shoulders and puts the head in alignment. Okay, so that's one thing to think about of slight extension. You don't want them so extended that it's occluded the other way, but you need to have something that puts them in the correct position to account for their giant head. So not only is their physiology different in that they respond with apnea, but their anatomy is different. Their heads are gigantic compared to the rest of them. So now you're trying to give them oxygen because they came out, it's a little bit low, so they didn't get any APGAR points, so they got one APGAR point. You're intervening as the provider. They do make these little BMVs, BVMs, bag valve masks, little teeny tiny ones that they have. So you get the child into that sniffing position, the neonate into the sniffing position. Your rate is your normal neonatal rate, so 30, 40 to 60 minutes. And then you are giving them just enough oxygen so that they have chest rise. You don't need to go all like Herculean efforts. You'll pop a pneumo if you do that. You're just trying to get that chest rise. So what would you do then if you can't get the chest rise? There's no clinical improvement. That's when you start thinking, I need to intubate this little guy or gal, right? So if you can't get chest rise with a non-invasive airway, or you need to give medications via an endotracheal tube. We'll talk about which ones you can give. Or if you're going to transport, right? You know now as your provider, I'm in Fort Camp Base Podunk somewhere, and my nearest NICU is 3 hours away. This child isn't breathing well. Well, I need to establish an airway first to transport. So if I need it for transport, if I need to give certain meds, and then if I can't get chest rise with a non-invasive airway, those would be indications to intubate. So we're going to fix ventilation first. Okay, we fixed the ventilation, or we fixed the airway, in our positioning, we fixed the airway. Now we're going to look at, oh, our heart rate is still really low. So it's below what? So you want to intervene with chest compressions? Below 60, correct. So now, if I'm giving chest compressions, a couple ways to do it. You can either encircle the baby and use your thumbs, or you can do the two-finger method. If you look at your fingers, and you look at them and you're like, one's longer than the other, how well is that going to work? Some people find that that works really well. I would recommend if it's going to be that first resuscitation, that you use both thumbs. Your ratio is 3 to 1. So has anyone done ballroom dancing here? No, great. Oh, great, we have one. Awesome. It's the same pattern as a waltz. 1, 2, 3, 1, 2, 3, 1, 2, 3. And you breathe at the 1, 1, 2, 3, 1, 2, 3, 1, 2, 3. Same pattern as a waltz. Medications that we are going to be giving then. So oxygen is a medication, specifically for premature infants. We will talk so much about why that is the case and why too much oxygen can make a child go blind. Okay? So oxygen is a medication. Your IV bolus. So here's our first metric scale. What is the average size of a neonate in kilograms? Just guess. 3 kilograms. Perfect. So if we are going to give 10 milliliters per kilogram, how much are we going to bolus this child? 30 milliliters. And just rough guesstimate, how much 30 milliliters is? It is 1 ounce. So a bolus for a neonate is 1 ounce. These are teeny tiny amounts. Okay, that is a bolus for that child. Okay, so if you're hypotensive, hypovolemic, mom had a hemorrhagic issue, we had a lot of blood loss with birth, and we're bolusing this infant, it's a small amount. So you're like, oh my gosh, we bolused. A bolus, just one overwhelming amount of something. You can bolus food, you can bolus fluid. It's still a teeny tiny amount. And then epinephrine, right? So indications for this, number one, if we had no heart rate, and we had already intervened with ventilation, now we're starting chest compressions. It's still asystolic, so we're not getting any chest, any heartbeat, would be an indication for epinephrine. Or they're unresponsive to the ventilatory efforts. This is one route that you can give epinephrine. So not only can you give it via IV, you can give it via IO, or you can give it via ET tube to a neonate. A little unpredictable, but it's an option. Rarely would you ever give Narcan, something to consider. So this is just a nice provider word. So some legalese here. If you consider things, you won't get yourself in legal trouble. You are not committing to it, but you're saying I thought about it. Okay? So consider is a good word to use here. So consider Narcan. However, what's going to happen if you had a baby with no prenatal care off the street who you give Narcan to because they're limp? What's going to happen? Cause a seizure. Yes, you can have now a neonatal seizure. Seizures take a whole lot of what? Glucose, correct. So now you're having this baby who is seizing, is having withdrawal, and now you put them into a hypoglycemic issue, right? So you can see how this badness ensues, right? So I would much rather control the airway for longer, help them, than give them Narcan. It's something to consider. So let's do a little check on learning here. You are walking down the hallway of the obstetrics ward and the nurse pulls you in and says that there's a precipitous, meaning it's happening right now. It's usually within 30 minutes from the time of arrival. A precipitous vaginal delivery to a 37-year-old, now G2 and P2. P2 female. So if you learn, you haven't had that yet, G's and P's. Gestational, how many times have you been pregnant? Number of gestations. And then how many deliveries have you had? So G2, P2 means she's been pregnant twice. And she's had 2 deliveries. The infant appears pink on his core, but blue on his hands and feet. His pulse is 110. He sneezes with bold suction. He's active, but has somewhat of a slow and irregular breaths. What is his APGAR? What is he getting for his appearance? A 1. What is he getting for his pulse?
2.
What is he getting for his grimace?
2.
What is he getting for his activity?
2.
What is he getting for his respirations?
1.
Public math, I have no idea what we do. Good. And that is how. So please be able to calculate an APGAR in a similar question to that. Okay. Again, what's the 1 minute? Birth. How did birth go? What's your 5 minute? How did you adapt, translate, and what score makes you say, I need another one? Less than 8. Yep. Okay. So, we've gotten through all of the OB review. We've gotten through the delivery. We got through the resuscitation. We got through the APGARs. This baby is good to go, stable with mom. Everyone's having a great time. Now what do we do? So that's the next section. What do we do now? So there's a couple of things that we're going to do. So standard nursery care, there's 2 different types. So standard nursing care means this is going to happen for every baby that walks through those doors, right? You don't get to go home without this type of care. So that's that standard care. And all of these things are things that we do because they're going to reduce some sort of morbidity or mortality later on in life, okay? So there's some stuff that we do right after birth, right after we got birth and resuscitation and APGARs and we're like, is everyone stable? You're good, I'm good, we're all good. And then there's some stuff that happens at the 24-hour mark. So those are our 2 camps. So this is standard care for everybody, immediate or 24-hour. Shortly after birth, so you're going to be on your rotations and you're going to hear, did they get eyes and thighs? And you're like, they have eyes and thighs, I think. Yeah, do they? Right? What do they mean when we say that? Eyes and thighs mean, did they get preventive medication to their eye and did they get that first injection into their thigh? So that is what eyes and thighs mean. So what are we putting in their eyes? We are putting erythromycin ointment into their eyes. And this is a trick question. This was on my words. They say, what is the erythromycin ointment trying to prevent? And everyone's like, chlamydia. You're like, it's not. It's gonorrhea. Okay? So you're preventing gonococcal disease, which confers a blindness risk with this erythromycin ointment. Of note, it's a misdemeanor in Texas for a provider to not apply erythromycin to a baby. So I tell parents, I'm like, you can wipe it out immediately, but I have to do it so I don't get a misdemeanor. Yes, ma'am.
So even if the mother doesn't have gonorrhea, you still have to do it regardless?
Yes. Regardless, everybody gets it. Yep. So that is an example of a conversation where a parent will sometimes be like, I absolutely do not want this. There are ways to document that. We can talk about that, of how you would do that, and saying I'm declining care and that kind of stuff. Yes, yes, yes. But in general, even if you have a negative gonorrhea or chlamydia lab from 2 weeks ago, you still treat the baby because it's a preventive. Was there a question back there?
Yeah, you answered, I was gonna ask, because I know in Texas there's a big, well, in the country there's a big push against like certain medications or
Correct.
vaccines. I was gonna ask
Yep.
what the deal with.
Yep, and a lot of that stuff is a conversation and a document that they declined it. How that law is still shaking out remains TBD. So that's your eyes. So we're preventing gonococcal disease with erythromycin ointment. That's the eyes part. The thighs part is then twofold. So we'll do the easy one first. The only vaccine, so this is an example of something where this would be the specific thing that you're learning about the vaccine, not necessarily the full schedule. The only vaccine that is given at birth is your hepatitis B vaccine. Okay? That's unique to that one. People always say, why in the world, right? Hepatitis B is a sexually transmitted disease or what is going on? Well, when they started looking at all the ways that it is transmitted, healthcare workers, years and years ago, healthcare workers were transmitting it to these newborn babies that they were taking care of. And so it was really small, it was like a 0.03%, but that was still significant to how children were getting hepatitis B. So that became what we now screen for in healthcare workers, and then we started giving the vaccine like right immediately upon birth to prevent that, right? So that's one of those conversations to have with families if they're like, I don't want this. Okay, that's reasonable. Let's talk about why we started doing it, why we still do it, why you would be at higher or lower risk, and document that. Okay, that's it. So hepatitis B, that's the standard offered vaccine at the time of birth. The other one is a vitamin K shot. What are the fat-soluble vitamins? A, E, D, and K, right? How good is a neonate, based on my question, at absorbing fat-soluble vitamins? Bad, right? Not that great at it. Where is vitamin K stored? In the liver, yep. And in the liver makes things that help you bleed more or less? Less, right? So now we have something, and then what are our stores of vitamin K, do you think, as a neonate? Yeah, not great, right? So now you have a situation where an infant who's susceptible to bleeding because they don't have these clotting factors, who also, one of the things that is needed to make that, they don't absorb that very well, right? So you're like, this is badness. And so there was, we used to call it hemorrhagic disease of the newborn, because infants who didn't have appropriate vitamin K were unable to make these clotting factors, and then scenarios where very minimal things would happen could cause some of those intraventricular bleeds we talked about from the first hour. And you would have situations where now you have hemorrhagic disease of the newborn, right? So super common in those first few weeks of life. And now when we give the injectable form of vitamin K, we basically give the liver all of that to help the liver jumpstart. We get all of those clotting factors so we see bleeding go way down. Some other contributing factors is that there's low amounts of that in breast milk, similar to why we give vitamin D. It just doesn't hold on to fat-soluble vitamins really well. And where you recirculate that in the gut, this is a sterile gut. It's never seen the light of day yet, right? So just not great with vitamin K. We have changed the name recently, and much to my chagrin, and we now call it vitamin K deficient bleeding. And so how low, like, if you're like trying to explain that to a family, not that you want to scare them, but it should be like when you see infants bleeding, it's a big deal, right? So if you're like, would you like to have this shot to prevent vitamin K deficient bleeding? It comes across very different than like hemorrhagic disease of the newborn, right? So just to be aware of what the names are and how we have changed them. So that is what eyes and thighs are. Every baby when they come out. The other things now, so these are the 24-hour mark things. So the things that we talked about. So I heard somebody say it earlier, we're going to check for CF. So that is one of the things that we look at on the newborn screen. So the newborn screen checks for things that if you intervened early would have a different outcome. Right? So if you're thinking, why don't we check for this genetic disease and this genetic disease where there's no treatment and no cure and nothing we're going to do about it is going to make a hill of bean a difference? That is why, right? If you're saying, wow, if we intervene early with hypothyroidism, we can prevent cretinism. If we intervene early with sickle cell, we can prevent asplenia. If we intervene early with cystic fibrosis, we can prevent some of the pancreatic and pulmonary complications, right? So things that are on a newborn screen are things that if you intervened early would have a different clinical outcome. Okay? So every state, the first one was PKU, phenylketonuria. So that's how it started. So you'll hear some people call it the PKU screen because that's what it used to be. And now each state adds different things. So I think Texas, has 42 different things that they test for with a small amount of blood. And so that happens at 24 hours of life. The reason why is you want to try to get as little mixing with mom and baby's blood as possible so that you're not getting mom's sample, you're actually getting baby's sample. The other thing that we're going to talk about is bilirubin screening, and I love bilirubin. There will be a question on bilirubin on your test. We will talk a lot about it, but that is one of the screens that we will have later on. A hearing screen, so we'll do that. A congenital heart disease screening, to look for infants who need further intervention or not. So we'll look at all of these specifically. So your hearing screen. So the biggest takeaway is that early intervention with hearing can drastically affect their outcome. And so you want to make sure, do you have a baseline of can this infant hear or not? So there's a couple of different types, and I don't need you to know the specifics in there. Are we doing an OAE or an ABR and the different waves? Are we looking at autoacoustic emissions? Or are we looking at the brain stem issue? We don't need, that's too much. Just know there's a couple of types. You fail one, you do the other one, you continue. The biggest takeaway is you need to have this infant screened, ideally at 24 hours, with definitive care by 3 months. 3 months. And you will hear this so many times. 3 months is your key. Congenital heart disease screening. So this one we are looking at what is the risk that this child has a congenital cardiac defect. So in block 3 we'll have a whole lecture on that, so we won't get into the specifics of that. But right now we are screening for who is likely to be that 1 in 100 baby that's going to have a problem. And so that's the numbers. Roughly 1 in 100 is going to have some sort of congenital cardiac disease. So we're looking for that one. Okay? So how are we doing this? Well, we are putting an oxygen saturation on their right hand. The right hand, because it is pre-ductal. So it is before the ductus arteriosus, and then after that, you can put it on anything else. So you're comparing their pre-ductal saturation of the right hand to a post-ductal saturation. So pick any other limb, right? A lot of times we'll put it on left foot, right hand, of thinking as far apart as possible, but really you could do it either way. And you are looking to see what is the difference in saturations. If you have no holes in your heart, quote unquote, or congenital cardiac issue, and you have 97% in one hand, you should have 97% in that foot. If you have some sort of difference, it's telling you that something is going awry. Okay? So if you get less than 3% difference, so if you have a 97 and a 95, it's fine. If you have a 97 and a 92, not good. More than 3. Or if that right hand is a 92 and that left foot is an 86, right? That's no good. So less than 95 or more than 3% difference. That's when you would say, ooh, what's going on here? Let's take a really good look to see if you are between that 90 to 94% in that right hand, or more than 3. We need to repeat that screen. And then if you're less than 90 in that right hand or that right foot, you're probably that 1 in 100, and you need to get to cardiology. That's how we're using these screens. If you study a different way and those words didn't make sense, and you like flowcharts, I will often do this throughout different lectures, where it is the same information, just said a different way. So if you like flowcharts versus the one that I chose at first to describe it, I just put it in there for an option for you. So the next part of this is the exam. Okay, so this little guy or gal has come out, and you do not know that this child is formed correctly. You cannot assume that all the parts, pieces, and everything is there. You can't assume they work right because they have not proven that. Right? So you are this first exam, and I guarantee you, when you leave, the parent parents, grandparents, or aunties, or auntie, or whatever, they're going to look this child up head to toe, and they're going to be like, did you see that freckle? Did you see this? So you better do a good exam, number one, because this is the first exam that this human being has ever had. Two, because we're looking for risk stratification of what could go wrong, what am I going to intervene on, and three, because you know that they're gonna look, so you should find it first. If you've never seen a newborn hold a baby, very uncomfortable with kids, and you're like, what is she talking about? There are some videos on there to watch somebody do it if you learn that way. Otherwise, we'll kind of talk through it here. This is just an FYI, but if you, how many of you guys have been deployed in here? Good majority? Okay. There's a lot of places there's not a whole lot of prenatal care, and so if you get there and you're like, I don't know, this baby is here, how old is the baby? We don't know, just delivered. There's a whole thing called a Ballard scale that is basically fancy baby yoga to be able to put them in different positions to be able to tell gestational age. I don't need you to learn the Ballard score, but if somebody tells you, we think this baby is 36 weeks based on the Ballard score, I want you to at least have heard that before. Okay, so FYI, please do not learn this or memorize this, just want you to be aware. When you're doing an exam, there's a difference between preterm and term infants, and sometimes if you don't know their gestation, they would use the Ballard score. Okay? So just some tips in general before we get into the nitty-gritty of it. Most of the time, I would recommend that you examine the baby in the presence of the parents. Number one, they can see what you're doing. Number two, they can ask questions and you start building that relationship between provider and parent. And then number three, you start to get a sense of how their bonding is, what their fear level is, what kinds of things are their questions and comments and concerns. Two, please keep the baby warm. They have a large surface area to volume ratio and they lose heat easily. Okay? So trying to keep them in warm environments will help. They have been in a dark environment for the last 9 months. So when you shine bright lights on them, they will close and clamp their eyes. That is the strongest part of the baby's body is their eyelids. And so they will clamp down and they will not want to open or they will start crying. So keeping a dim, nice, calm, warm environment is going to be very, very helpful. If you can catch a feeding with a family, that's also great. And then things to demonstrate some of the calming movements. So people think that grandmas were just making some of the stuff up. They were not. All of your calming maneuvers mimic the uterus, right? So if you're swaddling the baby, you are trying to put everything in the flexed position that reflects their time in the uterus. It's very comforting. If you're putting them side lying on their side, as opposed to up, that is mimicking the uterus. If you are swaying, that's what they were doing in mom for the last 9 months. She was walking around, right? If you're ever like, this baby won't let me sit down. Like as soon as the baby, I just have to stand the whole time. That's what mom was doing, right? Shushing, that baby lived right next to mom's aorta for 9 months. So when you're shh, 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 you're mimicking what they heard for 9 months. And then the suck reflex, so that is their comfort mechanism. We'll talk about reflexes as we go. So it helps demonstrate that and be able to talk to parents about why you would want to do those things. A few other things, be flexible, right? You have learned to start with head to toe exams, but if you have a quiet baby, I might start with the heart because you might not get another chance because they're just going to be screaming and crying. So things to think about, be flexible. Your observation skills are going to be huge here, right? You guys have learned provider speak for the last year, so there should be some words that immediately come to mind if you see something that isn't quite right or is healthy and normal. And then we are going to be able, we're going to look at every single thing. We're going to be prepared for the baby to pee on you. If you haven't gotten peed on, you really haven't done pediatrics yet. You're going to examine the baby fully naked to include the diaper off because you're going to get a good hip examination. And then you're going to do every single part of the baby. Your measurements are going to be in metric systems, so grams or kilograms. Again, not that I don't care, and families do, but 8.7 or 8 pounds 7 ounces is just not how we think in our provider brains. We are going to plot their amount according to their gestational age. That's what GA is. We're going to plot that and be able to say, is this baby healthy and normal based on predicted values or not? And I'll show you how to read those charts. Length is going to be very similar, also in centimeters. We are also going to put that on a curve for gestational age. We are doing this lying down, so up until the age of 2. However, babies are flexing all the time, right? So if you're trying to like straighten a baby out and get their exact length, like the length is probably the least accurate measurement, I guess, as I will say it like that, of all of the baby measurements. And then we're getting head circumference as well, because we're looking as a quick way to measure brain growth. Again, plotted for gestational age. So this is what that is going to look at. So this is that first thing, is part of your vital signs. So every single specialty, I will tell you this, when you go, every single specialty is going to be like, we have a 6th vital sign. You're like, our vital sign is pain. And you're like, okay. And then you're like, our vital sign is last menstrual period. And you're like, okay. I'm like, right? So like Peds has one too, and it is our growth charts, right? So think about it like that. Is I care about their heart rate, their respiratory rate, their oxygen. But if they're not growing, that's telling me something else is going on. So that is a vital sign. So for pediatrics, growth is a vital sign. So measured in metrics. So this is our first time we're ever plotting this. So the way we are reading this is the number of weeks for gestation is along your x-axis. So were they preterm, meaning less than 37? Are they term, meaning, and again, we're going to use 37, but this is a Peds chart, so it's 38 to 40, and then are you more than 40 weeks post-term? Your x-axis is going to be your weight in, this is grams, you can also do kilograms. And then you're looking at the black lines. So that is what I need you to understand what it is. So along this right-hand side, you are looking at 3 different things. LGA means you are large for gestational age. In the middle, AGA, you are appropriate for gestational age. And then guess what SGA is? Small for gestational age, correct. And so based on your number of weeks, where do you fall inside those black lines or do you not? Okay, so that is your first thing. So if you fall inside those 2 lines, those 2 tracks, you are AGA, right? So if you are, let's look at, let's say you are 32 weeks. Yes, 32 weeks, and you are 3,000 grams. What are you? LGA. What if you are 40 weeks and you are 3,000 grams? AGA. What if you are 46 weeks and 3,000 grams? Still LG or still AGA, correct. Yep. So that is your those black lines. Okay, now you have some other lines here. So the yellow is your absolute value. So I don't care now about your weeks. Once I switch to the colors, I no longer care about your weeks, and it's absolute value. So if you ever have a baby that is born under 2,500 grams, so 2.5 kilograms, that is a low birth weight baby. Doesn't necessarily mean that something's wrong, we're just capturing it for data. If you are under 1,500 grams, what do you think the V is? Very low birth weight, yep. And then if you are ever under 1,000 grams, you are extremely low birth weight, correct. And so if you are 40 weeks, you are term, but you are still 1,200 grams, right? You're still very low birth weight. So that is how the absolute values compared to your bi-week gestational for LGA, SGA, and AGA. So that's how you're reading that. This basically says that anybody under 2,500 is low birth weight. Prematurity is going to be your number 1 cause of that. You're early, you're probably going to be small. And then you're very low and extremely low birth weights. So risks for being low birth weight, right? We already talked about one of these. Did I put that on there? Oh, I didn't. But hypertension, right? No flow, no grow. You didn't grow, you might be much smaller. If mom just makes small babies, so if mom has had every single one of my babies is just 4.5 pounds, that's just kind of how I make them. Right? So previous LGA babies can be at risk for that. Young moms, old moms confer that risk. Drug use, tobacco use, low socioeconomic status, education levels statistically matter if you didn't have any prenatal care. And if mom didn't gain any weight, it's difficult for the baby to gain weight as well. So those are just some of those risk factors. So now that we've plotted them, so you will look not just at weight, you will do that same chart, so I just didn't put them on there, but you'll do the same chart for your length and your head circumference. So you could be AGA for weight and LGA for length and SGA for head, right? You don't have to, they could be all over the place. So the first thing that we're going to look at is actually the head. So the head is going to be made up of a whole bunch of your different plates in the head, right? So the head comes out all mismatched because it just went through the pelvis, right? So really, we think that we're putting hats on babies to keep them warm, but it's really because they look all calm heady. So all of those different plates should be open to allow for that birth process and then allow for the brain to grow over time, okay? So what you should be feeling is there's the occiput, there's the parietal, there's all the different plates, and in between each one of them are your sutures. And they should not be fused because they should be open. And so kind of the four corners region of a baby is their anterior fontanelle. What is that called in layman's speak? The soft spot, right? So no longer are you calling it soft spot, provider to provider, we are calling it the anterior fontanelle. That is just new provider speak. It should be open, you should feel it, you should feel a soft spot, and it should be flat, it should not be bulging, and it shouldn't be like a Grand Canyon. And if at birth it is not that, you have a problem. And what kind of imaging might you do for that? Ultrasound. You're doing beautiful. This is gonna be great. This is gonna be great. When they're so if it is small or fused, you worry that it fused too early, and that fusion too early of any suture is called craniosynostosis. And if it is way too big, if you're like, oh my gosh, this is like 5 centimeters, this is not a soft spot, this is a soft crater, right? That you get concerned that there's some sort of hypothyroidism, right? So we worry about infection and hypothyroidism. Two things you're gonna see over and over. You're looking at the shape, you're looking, are there any cuts? Did the baby have any electrodes that were implanted during birth? Is there bruising that you see with that? And so in general, you're going to be looking, and I don't need you to memorize these types, but to be aware that if you have fusion, inappropriate fusion of any of those sutures, it is craniosynostosis, but there are different types. So if let's say this suture, the coronal suture closes, now the brain can only grow back, and so you look like you have a bicycle helmet. First is if you have premature of those posterior sutures, now it grows up or out, right? So depending on what suture closes, you're going to have a different head structure over time. That's why one of the reasons why we bring them back for well visits and check their head each time. I don't need you to, please do not memorize the different types of craniosynostosis, just to be aware that when you call a pediatric neurologist and neurosurgeon, they will say, what type of craniosynostosis is it? And then you will go look it up, as do I each time. Okay. This, though, is a normal finding. So what you expect is delivery is rough, and so the brain and the different sutures are going to come over themselves and squish, and the baby's head is going to be very misshapen. So if you see that, they are overriding each other. If this is right after birth, this is an hour, this is the next day, it's a normal finding. It is an overriding suture. It moved to be able to go through the pelvis. If this is 2 weeks later, something is wrong. You would expect the head to have made a new shape at that point. So that's why the timing matters, right? So overriding sutures in a newborn neonate, normal. Couple of things then that are not normal, right? We just said the hat goes on for this type of thing, right? So depending on where you see this head shaping can determine, is this okay or not okay? So caput succedaneum, you will hear that called caput in a medical environment. Baby head caput, no problem. You're like, what is happening? Well, in this, you basically have edema from the friction of going through the pelvis, and so it is superficial edema of the scalp. Nothing to worry about, right? But it makes the heads look like that. That's what we put the hat on, right? So caput succedaneum or caput, It's all the C's. It's common. It crosses all the suture lines because it's just the superficial side of it. And it resolves on its own. So common, crosses suture lines, nothing to worry about. Versus a cephalohematoma. So in this, it is a deeper bleed where you have a bleed into your bridging veins. So it's a venous bleed. And now, since it is bleeding in that deeper level, it gets stuck at one of the sutures, right? It is not crossing that. And so now, because of that, you have, I can't cross, therefore I don't absorb very well. And so now those red blood cells are just going to continue to break down, right? So it sits there for a long time until it all breaks down. It doesn't cross the suture lines. It takes a little while to resolve. That is the difference with cephalohematomas compared to caput. So which one do I care more about as a provider? Cephalohematomas. Yep. Which baby is more likely to have jaundice because they have more red blood cell breakdown? Cephalhematoma, correct. The one that should make you pucker, when I say pucker, you run and freak out, is the subgaleal hemorrhage. So this one is super rare. This one you have a much deeper bleed even. So now you have a subapneurotic bleed underneath. Most of the time seen if you have a vacuum delivery. So if they have literally, and when I say vacuum, they literally put a suction cup on the baby's head. Somebody puts their foot at the delivery table and they pull this baby out. Pediatricians hate forceps and vacuum, but we also gotta get babies out, right? So in this one, it crosses the suture lines and it's a deep bleed, so it goes everywhere. The best analogy, and the first time I felt it, I was like, that's what it is. If you put a gallon bag of water and you felt a bag of water, that's what it feels like on an exam, and then you're like, oh my god, that's blood. And so if you have blood that is pooling, that is now extra vascular, you are worried that this baby is not having enough to circulate the rest. So you have a big bleed. Compression bandages to make sure we get that blood to absorb. And on exam, you'll see the ears rotated anteriorly because all that blood is pushing forward, okay? So things to think about then for these: caput, common, crosses, all the C's, common, crosses, right? The cephalohematoma, half, and it has the word hematoma, so the H's. Half, doesn't cross, hematoma. And then subgaleal is the one that you should go get help. The G's, subgaleal. Okay? C's, H's, and G's. And that takes us there. Questions, comments, concerns, anxieties, frustrations, miscellaneous toxicities? No? We are one day down with Peds. I don't even know how many more to go. See you tomorrow.